Good afternoon. Our next speaker is Dr. Sham Sundar C. He is a consultant radiation oncologist at Apollo Proton Center, Chennai, and has been associated with the institute since its inception and has contributed to establishing the program there. He has a special interest in pediatric genitourinary, bone soft tissue, and pediatric malignancies. So, Dr. Sham Sundar C, the stage is yours.
Good afternoon, everybody. Thank you, ma'am. I thank the organizers for the opportunity. So, is the use of proton over photon justifiable in genitourinary cancers? Am I the right person to ask or answer? I've been treating patients with prostate cancer with proton therapy for the last 5 years. We've treated close to 80 patients, so you know what I'm going to tell. So, with that, let me go inside. So, instead of the entire spectrum of GU cancers, I will touch upon its role in bladder and other GU cancers, but I will be mainly speaking about the role of proton therapy in prostate cancer. So, the questions that I'll try to answer through the talk are, is proton therapy oncologically safe? Can proton result in better oncological outcomes over photons? Can proton therapy result in lowering the incidence of acute and late GU and GI toxicities? And is it really cost effective for everyone? So, coming to the first question, is it oncologically safe? There is long-term oncological outcomes data with use of proton therapy. And in the second half of the talk, I'll try to say about can it be more effective compared to photons, and I'll try to explain my rationale and the hypothesis why I'm going to say that. So this is the first study that I'm showing. It's from Japan. Long-term results of over 2,000 patients treated with definitive radiation therapy for prostate cancers. You can see these are various risk groups of prostate cancers treated. And they have shown good results, expected results in terms of 5-year disease control in the low risk setting is close to 100%, and in 10-year disease control is close to 88% even in high risk settings. So definitely there is long-term data, and the toxicity that has been observed are also similar to what we have seen with photon literature. Then what is the toxicity that is this is another study which has shown that over 2,700 patients who have been treated with proton therapy with a median follow-up of 7 years, they have reported 5-year freedom-free biochemical relapse at 5 years and 10 years, and they have all shown gratifying results. So definitely it is oncologically safe. Not just this, there are many more reports establishing the long-term oncological safety of protons. So to summarize, with a follow-up of extending beyond 5 years, tumor control appears to be at least on par with IMRT. I agree there's no randomized comparison. These are all single institution, sometimes prospective, some are population-based data. Additionally, the outcomes appears to be consistent across multiple proton centers in different geographical regions, different timelines, and different patient ethnicities. So I would say that it's oncologically safe. Coming to the next question, can it be more effective? Why? How can I say it's more effective when I'm giving the same dose of protons and photons when we give the same day? How can I say it's more effective? So what we do is we usually equate all the adjust an RBE correction of 1.1 with to the entire total dose delivered with protons. But whereas what happens is the RBE is not a uniform single RBE that we apply. It through the length of the distribution deposition of proton beam energy, the RBE varies. At the entry, it's around 1.1. In the center, it's around 1.15 to 1.3. And at the distal edge, it could be as high as 1.7, which means that in the areas where the Bragg peak is deposited, we could be delivering more dose than what we have calculated. So that's why I say it could be potentially more effective because you're delivering more dose, more biological dose in the with proton therapy. So what deposition of more biological dose does? It causes dense concentration of DNA damage, and whenever the concentration of DNA damage is dense, the complexity of repair mechanisms are higher, so that leads to better oncological outcomes. So I don't say that it is effective. Can it be effective? I'm not sure. So, but there are some indirect comparisons using protons and photons. If you see in the low-risk CTs from the MSCGC and University of Florida Proton Center, in the low-risk setting, the outcomes are similar because we don't have much scope to improve those outcomes in prostate cancer. We almost hit the plateau of maximum outcomes that we could expect in the low-risk setting. Whereas in the intermediate risk group, use of protons have shown slightly better outcomes, but although these are large studies, these are population-based, and these are not randomized data. These are just indirect comparisons, and always indirect comparisons have to be interpreted cautiously. So finally, are they more effective? I'm not sure. They could be more effective. Then coming to the next question, can proton reduce acute and late GI and GU toxicities? So does it establish dosimetric superiority? Yes. I'll show a few examples of why I'm saying that. And toxicity among patients treated with contemporary IGRT, are they so much that protons could really benefit? Do we really see much toxicities with contemporary IGRT? And how does the long-term toxicity among proton therapy patients fare? So what dosimetrically what it does is, when we use proton therapy, this is a setting of prostate-only radiation, the distal fall-off in the high-dose region, which is where 95% to 80% isodose line, for every 1 millimeter distance from the target, proton therapy those distal fall-offs around 4%, whereas with IMRT is 2%. Similarly, in the intermediate dose regions, proton therapy is even more. The distal fall-off is around 6.2% per millimeter, whereas with IMRT it's around 1.5%. So because of the sharp distal dose fall-off, we will find dosimetric differences in patients we treated with proton therapy. So in our first 10 patients of prostate cancer that we have treated, what we tried to do was we made rival helical tomotherapy plans, and we plotted the bladder and rectum doses among 10 patients for every dose volume that we have planned. So, and based on these doses, we tried why is actually dosimetry relevant. Dosimetry is considered a surrogate of toxicity, number one, and we can see that the difference between the proton therapy and the helical tomotherapy plans are in the intermediate dose range, and they are much more in the low dose range. In the high dose range, there is not much difference between the proton therapy and the photon therapy plans. So based on this, what we tried to do was, we tried to calculate normal tissue complication probabilities based on the constraints which are there in literature and also NTCP models. So from the CHIP trial data, we note that intermediate and low doses are a surrogate for late toxicity, number one. And even from the POPRD data from India, we know that predictors of the genitourinary toxicity are basically intermediate and low doses. So we try to estimate the incidence of rectal bleeding, fecal incontinence, stool frequency, and several other toxicities by using NTCP formulas, by adding the specific values that we got in photon therapy plan and proton therapy plan, and we estimated the potential toxicities that could be there. So we have contoured some perirectal structures such as the puborectalis, levator ani, trigon of the bladder, because all these those to all these structures will result in late GI and GU toxicities in patients. So if you see the NTCP reduction with protons, so in terms of dysuria, the median NTCP reduction was around 5.83%. Similarly, it's seen across in all the toxicity subscales. There is definitely reduction in toxicity with use of protons. So when you sum it up, so the NTCP delta NTCP compared to photons is around 17% for the GI toxicities, and it's around 11.5% for the GU toxicities. So what toxicities are expected in these patients? This is, I'm trying to answer what does contemporary IGRT really have toxicities. 1 in 5 patients have around, 5 patients have grade 2 GU toxicities. 1 in 4 have grade 2 late GI toxicities. So around 20% and 25% of patients have late grade 2 GU and GI toxicities. And And not just that, the cumulative toxicity reported in the POP-40 trial was around 6.5, whereas if you see the PRO measures, we can say that a lot of patients had reported rectal bleeding as very much and also abdominal bloating as very much. So there is definitely a discrepancy in physician underreporting toxicity, so PROs are the way to go forward in future. Then coming to acute toxicities, they have also been shown that patients receiving pelvic nodal irradiation have larger acute toxicities, and it also has been shown in the POP-40 trial. The main reason for acute toxicities could be related to the dose received by the small bowel, and this can be definitely reduced with protons. You can see with the helical tomotherapy plan, this is the DVH of the bowel bag, and this is the DVH from the proton therapy plan. So thereby proton therapy has potential in decreasing acute and late GI and GU toxicities. So what does literature say? So there are no randomized data, there are some population-based studies, and there are some prospective single-arm studies. Some of them have reported increased GI toxicities with use of proton therapy. Majority of them have reported some sorts decrease, and most of them have reported equivalent toxicity outcomes with use of protons. So how do we explain them? If you see the existing literature, there's a lot of selection bias and there's a shorter follow-up. Most of the patients were treated before 2010 when pencil beam scanning was not available. Most of them were treated with double scattering or passive scattering proton therapy. There was no image guidance. Many patients are treated with a combination of IMRT and proton therapy. So, and most likely because of lack of image guidance, there would have been a larger PTV margin. So those are the potential reasons why we see a bias in reporting toxicities. So it's really an unfair comparison to compare the modern IMRT with the old technology of protons. So probably that's why these results were skewed and they are not relevant anymore. So we have treated all our patients under a registry trial. We call it the ProCube registry, prospective patient reported outcomes of patients of proton therapy patients for prostate cancer. We have treated close to 80 patients. A majority of them are in the high risk setting. Around 70 patients will be in the high risk group and the very high risk group, and most of them have received pelvic nodal irradiation. We have a median follow-up of around 24 months. Most of them have remained biochemically disease-free except for one patient who had a biochemical relapse at 50 months. If you look at toxicities, the late toxicities, no late toxicity was seen in around 80 to 90% of patients in GI. In acute toxicities, you can see that no toxicity was noted in 50% of GU patients, and GI toxicity was around 89 patients. So it is also, our toxicity reported also comparative to what is reported in literature. So definitely proton therapy shows dosimetric superiority by decreasing the low and intermediate doses received by rectum and bladder. Long-term GI and GU toxicity appears to be lower with protons, and our early results also show a similar trend in toxicity outcomes. However, we need longer follow-up data. Then coming to second cancer risk. Is it really there in prostate cancer patients? It is. This is a large cohort of patients from Japan who are treated with particle therapy, photons and surgery. The risk of second cancer is around 10 years, with particle therapy is around 16%, use of photons was around 24%, and the use of surgery was 18%. So definitely with particle therapy, the second cancer risk is lesser with protons. And this is from the CHIP trial. Among the 3,000 odd patients treated in CHIP trial, 300 were dead at the end of follow-up period, and out of them, around 100 had died of second cancers. So these are patients in the red, are patients treated with hormone therapy alone, whereas these patients receive radiation. You can see definitely the incidence of second cancers is more in the patients who have received radiation therapy. So proton therapy can potentially reduce these also. So does all proton therapy patients benefit with prostate cancer benefit with proton therapy? So how do we select patients? So there we bring in something called as a model-based selection. So if these are all the patients getting treated, some of them will have a very little benefit, some of the patients will have a major benefit. Suppose if you do an RCT and if there is a negative trial, even the patients who would get major benefit will not get the appropriate treatment. Suppose if there is a positive trial, even the patients with lesser benefit will all get the treatment that is required. So to an enriched population, possibly proton therapy will be more helpful. So majority of prostate cancer patients may not be suitable for proton therapy. It is eligible in a small subset of patients with proton. So what are those patients? So in high-risk patients that we treated, we applied the same NDCP formulas, and we found that around 70% of the patients benefited with use of proton therapy, number one. Next,
Sorry, Dr. Sham Sundar, please
almost
sum up
done.
in 1 minute.
Done, yeah. So in patients with baseline poor IPSS score, proton therapy seems to be beneficial, and in younger patients in whom the sexual function is essential to be preserved, proton therapy is definitely could be beneficial. So patients who are likely to benefit with the proton therapy, prostate patients requiring radiation to prostate as well as pelvic nodal radiation, or sometimes when you want to treat oligometastatic patients in the parietic nodal artery, patients with baseline poor urinary function, and young patients which focus on sexual health and wherein you want to prevent second cancers, all these are patients who could benefit with use of proton therapy. Is it cost effective? Several studies have concluded that proton therapy is not found to be cost effective. They may lower the mean complication cost rate, but ultimately the total healthcare cost is definitely higher with use of protons. So, in summary, is it oncologically safe? Yes. Can it result in better oncological outcomes? No, I do not know. There needs to be a randomized comparison. Can it result in lower acute late GI and GU toxicity? It's yes. Our studies, our research also show same. Is it cost effective? No, it is not cost effective for everyone, but maybe for a select group of patients. Just the last slide. In other GU cancers, if you see, there is proton therapy used in bladder cancers, especially when there was partial bladder irradiation. But now when we are doing total bladder irradiation, the proton therapy use is limited only in patients requiring pelvic nodal radiation. In penile cancer patients requiring pelvic and inguinal nodal artery, on a case-to-case basis, proton therapy needs to be discussed. Thank you. That's our team from Chennai. Dr. Srinivas Chilkuri was, I work in his team and he treats all the genitourinary cancers, and I've been part of his team from the beginning of the center. Thanks for the opportunity.
Thank you, Dr. Sham Sundar, for very precise talk. Just one thing I am asking you. I fully understand that your topic was photon versus proton. That's why you have not given any comparison with brachy. This morning we learned that everyone will agree that brachy is most precision. And IMPT versus IMRT versus brachy. In brachy, the conformity is much more for both HDR and LDR. I mean seat. So my humble, I just want to know, for case selection, should we give the option of brachy for brachy eligible patients?
So I agree.
Before selecting for proton.
So I agree that brachytherapy is the most conformal type of radiation that's available as of today. There is no doubt with that. Definitely it has to be an option that can be discussed with patients.
So the patient should be given the option to choose. Any question from the audience? No, thank you.
Before we conclude the session, may I request the chairperson to greet our speaker with a memento. Thank you, Dr. Sham Sundar, for the excellent presentation. Small token of appreciation for us. Thank you.